do in the spine today, mechanism of injury and basic anatomy of. So challenging area to interpret, I think. So lots and lots going on. So let's get through it. Okay, so obviously the spine starts at the skull, and we have the cervical, thoracic, and lumbar and sacrum, if you include that as part of the spine, or you could also consider it part of the pelvis. So we traditionally enumerate it with the first letter of the region and the number of the vertebral body. So it's very common for us to talk about C1, C3, T1, T10, things like that. We have two curvatures. There's a primary curvature of the spine. So when you're born as a baby, you have a primary curvature, which is the kyphosis. So the kyphosis here, which is the sort of, if you're looking from an anterior perspective, it's a concavity, yeah, anteriorly concave, and that's the primary curvature. And then after a few months of life, you start to develop a secondary curvature, and the secondary curvature is the lumbar lordosis and the the cervical lordosis, which is anteriorly convex. And this is how the baby starts to lift their head up. Yeah. So at the point where the baby starts to lift their head up, that's when they're starting to develop this other curve. And so the cervical curvature, the lordosis, appears first. Lumbar curvature is required before the toddler can start toddling. Yeah. So, all these really ambitious parents who want to get their child on their feet as fast as possible, there is this anatomical bottleneck. You can't get them toddling before they've developed a lumbar lordosis. So that's where we are. So they're the normal curvatures of the spine. Any lateral curvature is pathologic. What's that called? Scoliosis, correct. So that's curvature in the, which plane would that be in? Scoliosis, which plane would that curvature be in? Coronal plane. So, jolly good. And these are in the, which plane are these curvatures in? Sagittal plane. Great. Good. Helps if you drag it back from the memory vaults. Okay, so when you're looking at a spine, what you need to do is look at two vertebral bodies together as what's called a motion segment, because otherwise they don't really make a lot of sense. So looking at one individual one doesn't really make as much sense as putting two together in a motion segment. So the main features of the vertebral are the bodies and the intervertebral discs, like a bamboo-like structure that you get. In fact, there is a condition called bamboo spine where the intervertebral discs are calcified, and so it looks like bamboo. And then what you have is posterior elements. Okay, so all the rest of this can be termed posterior elements as one phrase for them. And then the posterior elements are split into various bits. So the main bits are the pedicles, which attach the bodies to the rest of it, and then the lamina, which make up the ring, the neural arch. So the pedicles and the lamina together make up the neural arch, and then you've got the spinous process exiting posteriorly. So the lamina fuse together to form the spinous process. Okay, and then you've got from the join of the pedicle and the lamina, you've got this body which has a superior process and an inferior process. Right, moving on, gets more detailed after that. So the superior process of the lower vertebra and the inferior process of the upper vertebra together form a joint, and that joint is a synovial joint, as articular hyaline cartilage on these processes, and there's a joint capsule and there's a little bit of synovial fluid in there, and it allows sliding and gliding motions like a plane joint, a synovial plane joint, and that's called a zygapophyseal joint. It's also known as a facet joint, so you might hear it termed a facet joint, and you may well have been in orthopedic theatre where people are doing facet joint injections, things like that. So they're injecting something into the joint space. Also known as an apophyseal joint, which I can't say, apophyseal, zygapophyseal, facet joint, apophyseal. So they're all the same thing, and they're these synovial joints that run up the spine. So the angle at which they slide and glide depends on the area. Okay, so for a lumbar vertebra, they tend to be mostly in the sagittal plane. For a thoracic vertebra, they tend to be mostly in a coronal plane, and for a cervical vertebra, they tend to be mostly in an axial plane. Yeah, so the angle at which the zygapophyseal joints are changes as they go up and down the spine, which allows different slight movements of one vertebral body on another. Right, all of this is held together with ligaments, okay, so you end up with various important ligamentous structures holding the whole thing together. So the first one here is the anterior longitudinal ligament, and that runs along the anterior surface of the vertebral bodies. And then the posterior longitudinal ligament, which we'll do in order. So that runs, the anterior longitudinal ligament runs from the occiput, which is the base of the skull, to the sacrum, so it runs the whole length. The supraspinous ligament right at the very back, posteriorly, that runs from C7 to the sacrum, and so that's the bit you can feel, so that's the bit that you touches against the spinous processes along the back of your back. And then between the spinous processes you have the intraspinous ligaments. Yep, so they attach one spinous process to another. Between the lamina, so between each lamina, the upper lamina and the bottom lamina, there's a little ligament there called ligamentum flava. And then the transverse processes, which aren't on this diagram, transverse processes that are sticking in a coronal plane coming out of the screen here, they're joined together with the intertransverse ligaments that join those together. The bit between the cervical vertebra C7 and the occiput, so the back of your neck here, there's a ligament which is the continuation of the supraspinous ligament, and that's called ligamentum nuchae. Yeah, so you shouldn't be able to forget that being from the northeast, or being associated with the northeast, because you've got nuchae brown ale, haven't you? Disgusting stuff. But ligamentum nuchae. Okay. Also known as the nuchal ligament. The posterior longitudinal ligament, I'm not sure that's going to be coloured in, but that actually only runs along the posterior aspect of the vertebral bodies. So that is running within the neural canal, attaching the posterior neural vertebral bodies together. Right, so just looking in the axial plane at a vertebra, so we're looking from the feet up here. So this is the left side of the vertebral body. We've got the CT slice here, and we've got the actual diagram. Now, the aorta is always slightly on the left side of the vertebral body. This is not to scale. It's a very tiny aorta in this diagram, but I just liked it because it shows the blood supply to the vertebral body, which is what we're trying to get across here on this slide. So any fracture of the vertebra is going to lead to blood loss. as you can see, quite a vascular structure. And there are a pair of arteries at every vertebral level. Yeah, so from the aorta in this case, the arteries are paired coming off the aorta to the lumbar vertebra. So here's the aorta in this case, with a bit of calcification and perhaps a dissection showing up here on this slide. Okay. You've also got the zygapophyseal joint showing up here. Yeah, that little black line there is the zygapophyseal joint, showing that it's mostly in the sagittal plane at the lumbar vertebra. This is probably about L3. No, it's a bit higher than that, isn't it? Probably about L2. We've got the kidneys here. And we're probably at the takeoff of that's probably the splenic artery, isn't it? Well, no, sorry, it's the liver, isn't it? The splenic artery will be over this way. So that's the hepatic artery. So, lamina join together to form the spinous process. Pedicles join to the vertebral body. Zygapophyseal joint. So if we look at one of these vertebra in isolation, there's lots of things you can identify, but the articular processes of these facet joints or zygapophyseal joints, you can see they're smoothed for articular cartilage. You've got the transverse processes. There's your inferior articular process that attaches down to the next motion segment, to the next vertebral body. And the mammillary process, which is just behind the articular process, is a connection point to the multifidus muscles, the tiny little muscles that join the vertebra together. The mammillary process there. Okay, so here's a quiz. So write down your answers. Okay, so our intent on this module is just to look at, adults and to look at mainly traumatic causes of injury. Obviously, that's not the only reason we image the spine. We're not looking at CT of the spine. The only reason I'm using this CT image is because it demonstrates quite clearly the musculature around the spine that holds the spine in place, which is obviously an important part of any traumatic injury. The muscles can hold the spine together, or indeed be the cause of that injury by spasm or contraction. So A, what is it? Psoas muscle, yeah. So iliopsoas, so it attaches to the lumbar vertebra and ends up being attached to the femur, allowing for flexion at the hip. Yeah, part of your core. So this is, are you all gym nuts? Go to the gym, do your core. Yeah. So this is what you're exercising for your core. And then B. What do we got for B? Not this high up. So erector spinae. Yeah. So the erector spinae. Which is a group of muscles. It's not one muscle, it's a group of muscles. In fact, that multifidus that we just described, that's part of the erector spinae group. C, what do we think C is?
Inferior vena cava?
Yes, so inferior vena cava is close to the spine at this point. It then gradually moves, as we move up the abdomen, it gradually moves away from the spine and goes anterior and then goes through the central tendon of the diaphragm. But at this level, what would this be? It's at the bottom of the kidneys, isn't it? These are the kidneys just going out, so it's probably about L3, L4. So that's it's a higher than L4 or 5 because we've still got aorta, which is D. So the aorta is enlarged in this case. Nearly every image that you get on the internet of an abdominal lumbar region has got an enlarged aorta because they tend to be abdominal aortic aneurysm injury images. So D is the aorta, slightly off to the left of centre, and in this case sort of enlarged and calcified with the white flecks. E, what have you got for E? Yep, so that'll be the vertebral body at the level of wherever we are, probably about L3. It's quite close to the end plate because it's quite bright. Normally, if it was in the middle of the body, then you'd see much more trabecular. So this is quite close to the end plate, so it's quite cortical. F.
Lamina.
Yep, so they're the lamina joining up to form G. What's G?
Spinous process.
Spinous process. Good. Okay. So yep. So that's what we've got there. So I've put erector spinae in quotes. If you're a physiotherapist, they don't like the term erector spinae. They think that's a bit of a cop-out, grouping everything together. They'd like to name all the muscles individually. So here is a diagram demonstrating some of the muscles of the that form sort of erector spinae. You can zoom in on this when you look at the slides back and actually look at them. These muscles here are multifidus, yeah, which go all the way up, and they're tiny little muscles that attach the spinous processes to the mammillary processes of vertebra lower down, and so they allow for flexion and twisting and things like that. And then you've got all of these other muscles. Most back pain that you will get referred to you on a chronic basis will be these muscles are implicated. Yeah, so that's why we try not to do too much imaging, because most chronic back pain is probably a muscular origin, which should really be referred to physiotherapy rather than be sort of like surgically corrected in some way. But everybody believes that all they need is a pin and plate and some surgery to get their back to scratch, don't they? Okay, so the neural canal, we've talked about the neural canal, which is this opening in the spine between the pedicles and the lamina and the body. Now it's filled with epidural fat. Okay, so this is the first thing that the neural canal is filled with, and then within the epidural fat we have the meninges. So the meninges are the layers of the central nervous system. So the external meninge is the dura mater, and then the middle one is the arachnoid mater, and then the one that's connecting up very, very shrink wrapped to the CNS is the pia mater. Okay, so you'll have met these in the brain, but they also encompass the spinal cord, and in fact they go beyond the spinal cord when the cord turns into the cauda equina, which is the sort of like tail-like terminal end of the spinal cord when it just turns into a lot of nerves. So that's past L2. So you get the space underneath the dura mater, which is called, which is filled with cerebrospinal fluid, and then you've got the subarachnoid cavity, which is reasonably open, and you can actually inject things into the subarachnoid cavity. But of course you would only do that beyond the spinal cord. You don't want to inject into the spinal cord. So you'd only do a lumbar puncture below the level of L2. So the other thing to note here is that at every intervertebral space you have a nerve root, a ganglion. So the nerve roots emanate at each space with a spinal ganglion and a spinal nerve, exiting at the intervertebral space. So have all these things in mind when you're looking at vertebral images plain X-ray images, because you need to imagine all of the structures you can't see, so that you can imagine what sort of things might be being pressed upon, or if there's a lack of space, or if there's too large a space. These are the sorts of things that you need to be looking at. Right, moving up to just some of the soft tissues in the neck. So here's the first layer of skin removed from the neck, and then underneath that you have a muscle layer called platysma. Okay, and then underneath the muscle layer platysma, you've got other muscles, and you've got some vital organs. Okay, so vital organs in the neck include the carotid arteries, which supply blood to the brain, jugular vein, which gives venous return, and you've got nerves as well, like the vagus nerve. Okay, so when we split the muscles away, then you can see the important blood vessels. And then we've also got blood vessels going through the transverse processes of the cervical spine. So there are 4 blood vessels effectively taking blood up to the brain. You've got the carotids, the internal carotids, common carotids and internal carotids, and then you've got the vertebrals, and the vertebrals lead through the foramen transversarium in the transverse processes of the cervical spine. Interestingly, they don't go, even though the C7 has a foramen transversarium, the artery doesn't pass through it. Bit of an anomaly. And then, of course, the 4 join together in the sort of circle of Willis, the roundabout in the brain, which is meant to allow some redundancy. So if one vessel blocks, then there should be some redundancy, and there should be enough blood pressure to continue to supply the brain with oxygenated blood. Also in the neck, looking at a cervical spine section at the level of C6. So here's our spinal cord in the neural canal. Here are presumably that will be, we haven't got a foramen transversarium on this diagram, but it would be around here, showing the vertebral artery. You've got, this is called the prevertebral fascia. This purpley pink line which goes around here. That's diagnostic. Helen will be telling you about how you identify a fracture due to enlargement of this space, the prevertebral space, on a cervical spine X-ray. So other structures of note at C6, we've got the trachea, we've got the thyroid, we've got the esophagus, the jugular vein and the internal carotid artery and the vagus nerve are in a carotid sheath either side. You've got sternocleidomastoid, which is the muscle that's evident in the neck, and you've got platysma. Okay. Have you seen the haka? Have you seen the New Zealand rugby team playing the haka? It's a sort of adaptation of a war dance, and one of the things they do is stick their tongue out, and grimace. And what they're doing there is actually tensing up platysma. So if you're a warrior just about to go into battle, if you tense up platysma muscle here, then what you're doing is you're creating a hard, tense structure which is hopefully going to protect these important vessels underneath. So by grimacing and screaming and sticking your tongue out, you're actually tensing up these muscles here. It's also good for keeping a nice neck instead of a turkey neck, they call it, don't they, that bit there. So you should have, in your beauty routine, you should be sticking your tongue out and doing the haka. Right. So there are those prevertebral soft tissues, just highlighted here. So what you're looking at is the trachea, the air in the trachea and larynx, and you're spotting the gap between that and the anterior border of the vertebra. So if you can't see a fracture, but if this is widened, then the blood, remember all that blood supply to these vertebral bodies, if they're fractured then they'll bleed, and the blood's got to go somewhere, and the idea is that it'll push this out. So if you see that widened, then there's a potential for a fracture. I'm not going to go into the detail because I'm sure Helen will do that, but there are certain, depending on where it is, there's certain levels, 10 millimeters, 10 millimeters, 20 millimeters, that you should be sort of measuring for. Okay, so just to make that radiographic, so you've got cervical vertebra 1. Remember that cervical vertebra 1 doesn't have a body, it's just a ring-like structure like a polo mint, and cervical vertebra 2 has a projection which is taking the place of the body of C1, which is called the odontoid process, or the dens. Okay, so the odontoid process of C2 takes the place of the body of C1. Okay, and then we've got C3, C4, C5, C6, C7, and T1. And we've talked about this. So apophyseal joint in this diagram would be the zygapophyseal joint, or the facet joint, as we saw it earlier. Okay, so again, Helen will talk about this. Do you do the open mouth odontoid peg projection? Yeah, still do that. Weird. I mean, the NICE guidelines state that you should be doing CTC spines now, shouldn't you? But you're still doing them as trauma cases. But the alignment you're looking for the alignment of C1 on C2, and you're looking for the lateral borders to line up, and you're looking for the gap between the odontoid and the internal border, and you're looking for the occipital condyles to rest on C1. So obviously if you collimate this off, so if you collimate too tightly and you miss that bit off, then it's not diagnostic, because this is what they're going to need to know. So you'd have to do it again. Again, looking at the lower cervical spine, you need to actually see the outer borders, spinous processes, and looking at the height of the vertebral bodies, etc., etc. And then there's these lateral lines that all ought to be in order. And again, I'm going to leave Helen to talk about those. More lines. So when you're looking at the skull articulating with C1, then you look for this dorsum sella here, and you look at the back of the sella, and you look at the EAM, and you draw a line, and that should align up with the bottom, the posterior aspect of the dens. Yeah, so looking at that line there. So mechanism of injury then, obviously for the spine, you've got crush, you've got avulsion injury where some of these muscles that are attached to various parts pull and can break bits off. You've got axial loading where the load goes down the spine. We talked about that already, haven't we, with Lover's fracture. What's Lover's fracture? Or Don Juan fracture? Yeah, and if you get that, then you should really be looking at the vertebral bodies as well, because that's an axial load on the vertebra. Insufficiency, so lots and lots of problems with osteoporosis, so you get more and more kyphosis due to wedge fractures of the vertebral bodies. Now, these four we're going to look at in a little bit more detail. So extension compression, so this is a extension injury with the head tilting back or the body tilting back, and compressive force at the same time. Okay, then you've got extension distraction, which is an extension injury but a pull. Yeah, so you've got two mechanisms of injury there which have extension. And then flexion, again you've got both. You've got flexion in compression, and you've got flexion in distraction. Okay, so we're going to look at those 4 because they give rise to slightly different potential injuries. Okay, so first one, the hyoid bone. I'm just going to include this and then sort of like bust the myth really. In any CSI type sort of film, they'll always say, "Oh, they've got a fractured hyoid bone. They must have been strangled." Yeah, but when they've actually done the research, they say it's only seen in 1 in 3 deaths due to strangulation. So the fractured hyoid bone as a strangulation indicator isn't necessarily a very good indicator. You're not likely to see it in the hyoid bone is obviously on the base of the tongue, and if you see a fracture, as in this case, it's most likely to be at post-mortem, because it's not something that you tend to fracture without having tried to kill yourself or be killed. Okay, so anyone aware of the cricketer Philip Hughes? So Philip Hughes was hit in the neck with a cricket ball, so the cricket ball actually smashed the transverse processes of the cervical spine, and that caused rupture of the vertebral artery. Okay, which then meant that he had blood loss, and he ended up not being able to be resuscitated. Well, he was sort of resuscitated at the scene. They got him into hospital, but he died of the injury. I'm not going to play the video because I'm running a bit out of time, but it's, you can play it and watch it if you want at your leisure. So any sort of like crush injury at the neck could potentially cause that problem. Next, we've got avulsion injury, so muscle pulls. So if you look at where the scapula is attached to the spine, so you've got trapezius, which attacks to the scapula and the vertebral bodies, and you've got rhombus, the rhombus muscles. Both of these are going to be used extensively in moving the arms. Yeah, so if you're using them to move your arms about, then you're going to be putting a lot of force on the spinous processes of the cervical and thoracic region. Okay, and you can actually, with very severe movement of the arms, you can actually pull off the spinous process of C7. It's an avulsion injury of the spinous process of C7. And it's known as clay shoveler's fracture, yeah, because clay shovelers digging clay can actually pull off the spinous process of C7. There's somebody shoveling clay. Believe it or not, there's a world championship.
I started boxing and I became pretty good at it. Went to the, I won 2-time Golden Belt champion here in the city of Cleveland. I went to the Olympic trials for the Goodwill Games in '91, for the Goodwill Games, the 1992 Goodwill Games. Went to Lake Placid, New York Training Center. Went to.
Apparently, you can dig 42 graves in an hour or something, which is pretty good going. Right. So, a blow to the top of the head. So this is going to be axial compression. Yeah. So the lordosis is protective and helps to give some flexibility, but you can otherwise get catastrophic spine injury. So the most likely fracture of an axial compression force, so something landing directly on the top of your head, or spearing, which is there's two tackles which we're going to be looking at in sport in a minute, both called spearing, but they're different. So the one in American football, they have a spearing tackle, which is where one footballer uses his helmet as a weapon and just runs into the opposing player, and they call that spearing. And so that would give you an axial force in the cervical spine. And what tends to happen is the cervical vertebra C1, which is this ring-like structure, fragments. Yeah, so if you have axial loading, C1 will splint, will fracture and break. Okay. So here's somebody going to demonstrate it.
Because of the extreme dangers inherent to this test, we asked Quentin to take extra precautions to make the tackle at only a quarter of his normal speed.
Do not ever try this at all.
Dramatic. So that's how you fracture C1. Yeah. So it's known as a Jefferson fracture, and these are the common places that the ring will fracture, but it will never fracture in one place. Being a circular structure, it will always fracture in two places. And you'd identify that by this being outside of the line of this. Yeah. So you might not see the fracture, but if this gap between the dens is abnormally large, and this outer border is beyond the outer border of C2, then that would indicate a Jefferson fracture, especially with that mechanism of injury. You could also see it on the lateral if the gap between the dens and the anterior portion of C1 is enlarged. There's the little ligament there. Now, you'll also see an insufficiency, not a fracture, but an insufficiency if you get an enlarged area between the anterior portion of C1 and the dens of C2. That could be due to a ligament injury. So the ligament that holds the dens in place could be torn. Okay, so this ligament here holds the dens tight in this place, and rheumatoid arthritis can actually cause this ligament to be lax, and so I don't know, have you ever x-rayed a patient prior to anesthesia, a rheumatoid patient, to check this? Because quite often the anaesthetists, before they tilt a patient with severe rheumatoid arthritis head back, they want to know that the spine is intact, because what you don't want to do is have somebody who's got a lax ligament or a torn ligament here, and then you raise their chin and try and do a laryngoscope on them. So they might ask for a lateral C-spine x-ray to check that. So that's not, it's not a traumatic event. Well, it's an insufficiency of that ligament, which would mean that you shouldn't really move the patient's head in the normal way. So extension compression. So this is somebody who's compressing the spine and raising their chin at the same time. Yep. So most commonly diving into shallow water. So somebody did a literature review of these injuries, and they found that they were mostly a summer injury, surprisingly, 88%. They were mostly young people, and most of them were men. 33 out of 34 cases were men diving into shallow water. Okay. So here's the typical scenario. Yeah. Run across the patio and jump into the inflated pool in the garden, which is about 3 feet deep. Yeah. And so, of course, what happens is you hit the ground with your chin and you get compressive force, extension force, and it doesn't go well. So the most common injury in that case is the fracture to the dens. Yeah. But also fractures to the posterior elements, because if you look at the spine, you imagine you're doing that with the spine. So you're putting huge pressure on the posterior elements, so some of them are going to break. Yeah. So you're going to get fractures of all these areas here. Okay, so extension distraction, the opposite in terms of a pull force now, and this is hanging. Okay, so somebody hangs themselves, then you're going to get an extension force, but this time there's going to be a pulling force on the neck, so it's going to pull apart the vertebra. So that's not going to cause fractures of the posterior elements because they're being pulled apart. This is a really scientific method used in France when they were doing judicial hangings. They put this device here to make sure that the head distracted as much as possible, rather than leaving it to chance. I would require an 11-foot drop apparently, using the calculator that they would use to identify whether or not I would die or not. So it's going to be a forced hyperextension distraction. So it creates a tension in the anterior longitudinal ligament, so it will tear the anterior longitudinal ligament, and usually a avulsion fracture called hangman's fracture. Now, how else can you get this injury? Judicial hanging's quite rare in the UK, thankfully. It's not, hanging itself is reasonably rare in the UK. So the other way of doing this, of course, is through motor vehicle accidents. So if you notice that how your head is there being pulled back, that's from a rear shunt. So if somebody comes at the car from the rear, hits the back of your car really hard, then your head, with its certain moment, with its mass, is going to remain where it is, and your body's going to go forward, and you're going to end up with this. It's commonly referred to as a whiplash injury, but you can get hangman's fracture from that, and you can get this anterior ligament fracture rupture from that. You can also get it if you get an uppercut from one of these massive, notice his 10-step platysma there. So here's our motor vehicle extension distraction injury. And I don't know if you get in your car, if you're a tall individual, do you always just get in the car and just drive off, or do you actually raise the headrest to the right height and make sure that it's there? Because that's what it's for, it's to stop this. So that if your head was to go back, it goes back and hits the headrest, rather than causing you such injury. So always make sure that your headrest is, public information, Phillips public information, always make sure your headrest is correctly adjusted for your car. So here's a crash test dummy.
At Euroanchor, we're simulating rear end to treat and often lead.
Whiplash is typically occur when the occupants of the struck car are rapidly pushed forward by the striking car.
In a real crash, you will get a push from behind, and then your seat will deflect, and if you have a bad seat, it will only support your back, and your head will stay free to move, and that will result in your head-neck system being pushed in an S-curve.
A good seat can protect the occupant by...
There you go. Anyone like classic cars? This is a brilliant movie, The Italian Job. Yeah, the premise of the movie is that they used minis because they could get them in the sewers of Turin to get the gold away. So this is them having got the gold out of the, and then being chased by the cops. What we're looking for here is the lack of head restraints in the minis. Gonna do a jump now. Right, so point being, if you ever look in a Mini, the back of the seat is about here and there's absolutely no head restraints whatsoever. So classic cars, great, but quite dangerous to be shunted in. Okay, so flexion compression, we're on to flexion compression now. So this is the other spear tackle. This is the one that you see in rugby. It's banned in rugby in the UK, but I don't see this as really being a spear tackle, but it's the way they call it, a spear tackle. But it's different to the American football one we saw earlier. So let's go and look at this. So what it is the best. There's no best about it. So what they do is they lift the player up and then dump them on the ground head first, yeah, and so you end up with flexion compression. So this is very severe, and these immediate, they immediately get multiple match bans, don't they? And they get sent off, and if they do that. So, and the reason for that is because it's one of the ways in which the what you're looking at here is an occipital condyle being dislocated from the cervical spine, and that's how you get that. And that's rarely survivable. The only time you'd see this would be on a post-mortem film. That's a really flexion compression injury. There are a couple of videos here of somebody doing a failed forward flip and landing on their head. Failed back flip, I think it is, and landing on their head, and they apparently died. So I'm not going to show them, but horrendous. So the other thing that you get with this is a teardrop fracture. Okay, so the posterior ligament can be torn, and because now the compression force is on the anterior part of the cervical spine, you end up compressing the anterior part, and you end up with a little bit of the body being broken off, and it looks like a teardrop. So I've got a picture of that here. So there's the bodies, and there's the teardrop fracture of the anterior portion. And again, now we're looking this way, this is the anterior side. These are the bodies, and there's the teardrop pulled out of C6. And that would be a flexion compression injury. Okay, flexion distraction. So again, this is high energy car accidents, frontal impact this time instead of rear impact. So you're driving along and you hit something, and your head gets pulled forward. So now you've got flexion distraction forces, and it can lead to facet joint subluxation or dislocation, because you're basically just pulling the spine apart. So there are the facet joints in alignment in the cervical vertebra, and if you flexion distract, then the facet joint can slide over itself and end up tearing the interspinous ligament, and the whole anterior portion moves forward over the posterior portion. So what you're looking at here is you're looking for the line on the posterior aspect of the vertebral body, and you're looking for anything more than 3.5 millimeters in gap between the posterior body borders, and you're looking at this facet joint sliding over. So that's called facet joint subluxation, and you'll also see a wedging. And facet joint dislocation, as it says there, very bad, because obviously the spinal cord is trying to make its way along here. So this is like you know, like those cigar cutters where you've got a circle, you put it into the cigar, and then you use that as like a guillotine. So you're effectively guillotining this the spinal cord. So in Formula One, they've used the hand system to stop this happening. So this is where you get these attachments to the motorcycle, or to the helmet, to the, not the motorcycle helmet, to the Formula One driver's helmet, which is attached to straps, which are then attached to their shoulders. So it tensions up and stops the head going forward. So that's the hand system. Okay, so most of those have been cervical, but you can get flexion distraction injuries in the thoracic vertebra as well, and the lumbar vertebra, and that's normally by something called submarining. Okay, so submarining is where you wear your seatbelt, but you don't wear it tight enough. Yeah, so my wife is a typical example. When we get in the car, if we're going out, and she always pulls the seatbelt like this and holds it away from herself because she doesn't want to mark her dress or whatever. Do you do that? Do you drive in the car with the seatbelt slack? So if you do that, then you're potentially going to submarine if you do have an accident.
Oriented ASN, and these tests showed clear training.
Right.
When accident victims slide forward underneath the lap strap.
Yeah, so there you see what's happened there is you get that flexion distraction, but at a lower point because of the submarining. So that can be the lumbothoracic junction tend to get flexion distraction injuries at the lumbothoracic junction. So all of those, fracture of the posterior elements, either in distraction or compression. Okay, final one I think is chance fracture, which is the compression. So this is the one that would come from submarining. Yeah, sorry, I've got my slide slightly wrong. So you get compression of the vertebral bodies and fracture of the posterior elements. So that's called the chance fracture, where you get both, and that will be from flexion distraction. Submarining being the most likely cause. So spondylolisthesis means slipping of one vertebra on another. So here we have the normal alignment of the lumbar vertebra, and if you get the superior portion slipping forward, that's called anterolisthesis, and if you get the superior portion slipping backward, then you get retrolisthesis. So that's the terminology, but both of which are spondylolisthesis. Okay, repetitive stress. So this is spondylolysis rather than spondylolisthesis, and basically it's a stress fracture of the pars interarticularis. Okay, the pars interarticularis. So in our vertebral body, where the pedicle joins the lamina, you've got this bunch of bone, and then that leads to the superior articular facet and the posterior articular facet. Between those two, this is known as the pars interarticularis. Okay, and if you get a fracture on that, then that's commonly a stress fracture. Okay, and this is where you get the idea of the Scotty dogs. So here's a Scotty dog. This is an oblique spine. So this is an oblique lumbar spine. So the pedicle is the eye of the spotty dog, and the neck is the pars interarticularis. And if you've got a collar on the pars interarticularis, just here, then that's a stress fracture due to mostly athletic individuals who've put too much pressure on their spine. Compression fractures due to insufficiency because of osteoporosis, you see these all the time. And that's the end of the slideshow. So lots more